Okay, so we already kind of described this, but I want to bring us back to this sort of foundation of the title of this class. So pathology is the study of suffering. It bridges clinical practice and basic science. And it's one of the reasons I really like this class so much. It's a very translational class. And so if you are more interested in basic science elements, or if you're more interested in the application, then this is a great class for you because we get to talk about both. And you're going to see that in today's lecture. So we're going to see more of the clinical practice and the clinical issues first, and then we're going to get, after the break, into the mechanisms of action, where we're going to talk about the basic science. And it might help you learn a little bit about yourself. Some of you might be fascinated with the clinical translational aspects. Others may be really interested in the mechanisms. Or you might say, you know what, I really don't care what's happening with the transporter, okay? I just want to know, like, how do I fix the patient? So you're going to get some insight as to kind of where your bent is, if you will, what you're more interested in this class. And I think that you should be honest with yourself and pay attention to it, because it'll help you make some decisions about your careers. So we investigate the causes and the underlying mechanisms that take place within these various diseases throughout the semester. In SI section last week, did you guys go over some diseases? Did you guys do that little exercise of 5 diseases that you think of? And hopefully what you saw is you guys can come up with a lot of different types of diseases. And this is a general pathology class, so we're not going to cover all of them. We're going to cover the ones that are more classically described, like in textbooks. We're going to cover the ones that are a little bit more historic. There's a lot of information about them. Okay? The reason I'm saying this is it's not inappropriate for you to come in and say, hey, we're not covering this disease in my class, or in this class, but I wanted to just pick your brain about this. And that's fine. In fact, one of your colleagues came in last week to do just that. Okay? And it's not a disease that we cover in depth. It's actually a disease that really not much is known about. Essentially, it was discovered in the last 20 years. Okay? And that's Huntington's disease. Okay? And you know who you are. I won't embarrass you, but I like when that dialogue happens, because we don't have time to talk about everything here. And if you're taking this class and it's like, oh shoot, I was so interested, but we're not talking about that. So now I'm just going to rank this class terrible. You know, why don't you just come in and let's chat about it? And we can chat all semester. But I won't quiz you on all these diseases, because we got to pick some classic ones that cover a broad depth of all the systems. Okay, so cellular adaptation. We need to talk about kind of when we see an injury, what's happening at the cellular level. That's one of the first things that we need to cover today. Let's look at it. So, at the very top of the slide is a normal cell, that we have this described in this box of homeostasis, where it's behaving under normal equilibrium. And there's fluctuations, as you learned about 201. And you probably talked about in 202 as well. And then we see that there is, on occasion, stress or an increased demand on that cell. And the cell will adapt. Our cells are amazingly plastic. Right? I keep saying that word. What does it mean? It means the ability to do different things. They're not rigid. They can actually change. There's always a range in the body that's considered homeostatic normal. Okay? It's not like your pH of your blood has to be 7.4. Now, mostly it's around 7.4, but the range is about 7.35 to 7.45. So there's a range that you can behave in and be fine. Right? Sodium blood levels. Right? They are also relatively tightly controlled. But it's not like they have to be exactly at 140 milliequivalent. They're at about 140 milliequivalent, plus or minus 5. So about 135 to 145. So what happens? What happens if it gets to 119, like in my mom last week? Well, then you get lethargic. Okay? You don't feel yourself. You sleep more. You might be more forgetful than normal. But you don't just immediately lose it. Okay? So your body has the ability to adapt but you try to tightly regulate this. If you can't adapt, then you injure the cell. And that's where this class is going to come in, is where adaptation doesn't take place appropriately. And you get what we call subcellular alterations, things that happen inside the cell, like to the nucleus or the mitochondria, the Golgi apparatus. All of those subcellular organelles, something will happen to them inside the cell. That's why you studied them, okay, in 181 and 201. You studied them because they actually are important for your future work. And you're going to use it in this class. And so hopefully some of the connecting the dots of, I really didn't care about the nucleus. Okay, I could draw it, right, in lab, but I didn't really care about it. Well, you might start paying more attention to it now. And hopefully you know when the nucleus is gone, that means the cell is dead. And you're going to see pictures today of cells without nuclei in them. And that's an indication that they're not alive anymore. Okay? Well, some of this can be reversible. You could, if the nucleus is intact, okay, and if the nucleus is still functional, and you lose some of the organelles, the nucleus can help send the signal to manufacture new organelles. If you lose a portion of the cell membrane, you can patch it if you're quick enough. If you put holes in lots of places in the cell membrane, then it's not reversible, okay? And so you're going to see that there's a point of irreversibility, and that leads to necrosis of the cell and ultimately necrosis of the tissue. And that's this pathway. Well, if you have the inability to adapt in cell injury, you could actually skip this direction. You could go straight towards apoptosis. Who knows the definition of, or a working definition of apoptosis? Programmed cell death. Okay? Programmed cell death. That's another way of saying that is the cell makes a decision, you almost might say a conscious decision, that I am going to get rid of myself because it's no longer beneficial to have me as a cell around. It's self-suicide is what it is. Okay? So we're going to talk about where biologically is that valuable. Okay, where is that something that the cell or the tissue or the organism benefits from? All right. But first, before we go deep into necrosis versus apoptosis, which we're going to compare and contrast today, I want to talk about some of these definitions. We're going to see some adaptations when the cell is under stress, and some of these adaptations are going to be physiologic and some are going to be pathogenic. So, physiologic adaptation. This is an adaptation that's a result of a normal process. So, for example, embryonic development. There's a lot of physiologic changes that take place in utero. And that's under normal physiologic processes or adaptations. Secondly, pathogenic. This results from a disease state. So you saw in Barrett esophagus physiologic or pathogenic adaptation. Pathogenic, very good. Atrophy. Atrophy is what? The cell itself is going to shrink in size. Atrophy, that's another adaptation that can take place to the cell. Hypertrophy, that's the opposite. The cell gets bigger in size. Hyperplasia, you increase in cell number. And metaplasia. Metaplasia is one cell becomes another cell type. A perfect example there could be Barrett esophagus, like we just talked about. Okay? So these are working definitions that we're going to see throughout the semester. So I want to throw up here, not literally throw up here, but put on the slides, an example that we'll talk about later in the semester, all the way at the end, cardiovascular. But just to prove the point, we're going to start with Barrett, and we're going to end with cardiovascular, and we're going to see some of the exact same mechanistic processes all throughout the semester. So it's kind of a cool class because if you get that part, you kind of figured out the secret to the class. Right? You're just going to be studying one disease state after another, and there's going to be a lot of similar processes that you should look for. So the first one was Barrett esophagus, and one of the last ones, I'm going to show it to you today, is heart attack. Okay? okay, or a myocardial infarction. So here's a normal myocyte drawn in cartoon. And if it wants to adapt to a stress, let's say, for example, there's an increase in load on the heart. That increase in load on the heart can come in the format of afterload, an increase in afterload. Okay, I remember that word from like 202, but it's just not coming back to me very quickly. Afterload is the load the heart experiences as it's trying to beat, right? Another way of defining it would be mean arterial pressure, okay, or blood pressure. So if blood pressure in a patient is elevated, that means the heart has to work harder to open the aortic valve and get blood out. It's a working muscle. If you load skeletal striated muscle or cardiac muscle, what happens to it? It gets bigger. Use a word we just learned about. It does what? It hypertrophies. Okay? So here you have a hypertrophic myocyte adapted to an increase in load. Right? And if you take a cross-section through the heart, that's actually this type of section right here, which is a transverse horizontal section. And so you're looking at the left ventricle on your right side and the right ventricle on your left side. Remember, it's the patient's left ventricle and the patient's right ventricle. And then you look at the left ventricle of a hypertrophic heart. Look at how thick the myocardial wall is. You're like, oh, I thought that was steak. Like, no, that is a section. Okay, you might need cannibal, but that is a section through a patient's left and right ventricle. Okay, about mid-papillary muscle. So this is the response that happens in a lot of patients that have high blood pressure, or in patients actually that use long-term steroids for performance enhancement. Okay, you get hypertrophic heart. Now on this side, now if you lose the load and you get rid of it, it will adapt backwards to a certain extent. You can actually see some regression or some atrophy if you take away the load. Now here's an example of a cell injury. Let's say, for example, you cut off blood supply to that working muscle. And that's in the format of occlusion of a coronary vessel that feeds that working muscle. Well, now you have no more oxygen. Well, if you don't have any oxygen left, then you lose the ability to manufacture ATP. If you lose that ability to manufacture ATP, you start seeing injury that takes place and subcellular reorganization. And if it persists, you won't be able to maintain the integrity of the membrane, the phospholipid bilayer. You won't be able to make additional ATP, so you won't have any more energy to actually run cellular function. And you're going to lead to cell death. And this right here, this different coloration, you see kind of that yellowish, and here's a little bit of a black area. This is a myocardial infarct. It's also known as necrosis. And a specific type of necrosis we're going to talk about here momentarily is called coagulative necrosis. Okay? So this is the whole gamut. That's the whole semester. From Barrett to myocardial infarction. That's the whole semester. We're going to fill in a bunch of systems in between, but we just bookended the entire semester right there. Okay? Any questions so far? Just want to take the final now and see how you do? Okay. But I do promise you we'll come back to a lot of these processes throughout the semester. Okay. This tends to be a trip-up question for students on the first exam. I don't know why. This summer I was looking at some of the performance over the years. And when I asked a question about this, I don't know if you're still thinking about the heart and you can't look at the brain right after that slide, but I thought I would just give you a heads up. Okay? Good? So this is the brain, and we've got two different brains. What are some things that you notice between the two different brains? One smaller than the other. Very good. What else? Increased ridges. More prominent ridges, right? Maybe the opposite is true too. More prominent valleys, right? So on the left, we have a normal brain of a deceased 24-year-old male. Okay? And you can see the relative size, same magnification. These patients were about the same weight. And this is an 82-year-old male on the right. So you can already see that with age, you get dumber, as you can tell by this picture. But the size of your brain actually shrinks. You have an atrophy of the brain. And not only is the overall brain size less, but the amount of material decreases within that same footprint. And that's why you're seeing more prominent valleys, right? So the valleys are what? Sulci or gyri? Sulci. So the sulci are more pronounced, and they're darker than over here. So this is what causes this. Why in old age will you see changes in gross observation or gross pathology of the brain? Any ideas?
Don't we stop? I mean, as we grow older, we still use the same amount of neurons, but the ones we don't use, we don't feed them anymore, right?
That's true. So the old proverbial statement of if you don't use it, you lose it. So you're born with generally all of the brain cells that you're going to have, all the neurons that are in existence. And as you get older, they die off. And so by the time you're in your 80s, you have less neurons than you had when you were first born. That's absolutely true. Okay? And then you pre-select. You pre-select the ones that you're going to let apoptotically divide off or die off. Those pathways that you're not using. Okay, so you're born with more than what you need, and then you only keep what you're actually actively using. This is one of the reasons that in a stroke patient, physical therapy is so helpful. Because if you catch the patient in an earlier phase of life, okay, you can try to reroute neuronal circuitry to do some of the same activities using neuronal pathways that weren't being used. Even though the one that you were using is gone, you might be able to find another pathway to do the same thing. Okay? So that's why, and it's more effective PT in younger patients than it is in older patients. So that's absolutely true. Here's another one. And you're going to see this at the end of the semester. The vessels that feed the head, the main vessels are the carotid vessels. And throughout our lifetime, we just build up a little bit of disease on those vessels. And so by the time you're in your 80s, you're going to have a layer of atherosclerosis on these vessels. It doesn't mean you're going to have a stroke. It just means instead of being this wide open, they might be about 40% reduced. Okay? So if you slow down slowly over time blood flow to the brain, you're not populating it with as much oxygen as you did when you were in your 20s. Okay? So exercise, routine exercise in our geriatric patients is very good. It actually helps keep brain function strong. So two big differences between a 20-year-old brain and an 80-year-old brain. And they died of unusual circumstances. It wasn't a stroke type of thing. And obviously a 20-year-old you don't expect to pass in their 20s. But it wasn't anything to do with neuronal circuitry or to the central nervous system. Okay, atrophy, an example of hypertrophy. Hypertrophy. So the first atrophy was an example of what we would consider a physiologic, one could argue pathogenic, age is pathogenic. Okay? This is classic physiologic example because this is the uterus. So this is a pregnant uterus, what we call a gravid uterus, the big one here. And then the little one here is a normal, non-pregnant uterus. So you can see very easily the increase in size of the hypertrophy. If we look histologically between the two images, the smooth muscle that's normally found in the uterine wall is what's depicted by this hematoxylin eosine stain. These are smooth muscles that look like spindles. So a spindle is going to be kind of wide in the middle and kind of go to a point here like this. So that cell type kind of looks like a spindle, and this is in a non-pregnant uterus. Over here, you can kind of appreciate the best example is like right here. You see this one right here? How it's round? It's not spindle at all. So instead of being, it's round like this, instead of being kind of spindly like that. Narrow on the ends and kind of fatten a little. And so this is a gravid uterus, and this is the increase in cell size that takes place with a pregnant uterine wall. A normal physiologic response. Now, we also use this example to look at hyperplasia, which is an increase in cell number. Also a normal physiologic response in mensing-aged women. So the folds in the endometrium that you see right here, there is an increase in the number of glandular cells that are present in this uterus during pregnancy, as well as on the hyperplastic and hyperplasia side of the menstrual cycle. Okay? Right before the period begins in a female, the uterus is actually ready for implantation. You probably remember this from 202. And if implantation isn't going to take place, then all of this additional tissue is sloughed off in the mens. Okay? And the cycle resets for the next 28 days. Okay, so this is a normal physiologic response that takes place in females every 28 days. Hyperplasia as well as hypertrophy. Now, the last example in this category is metaplasia. So this was just that slide that we showed where we were defining all these terms. This is back to pathological. So metaplasia doesn't occur under normal physiologic conditions. We saw metaplasia with Barrett esophagus, right? So I'm already referring back to Barrett. I've done it at least twice. So you're going to use that all semester just to remind you of kind of what the first example was at the beginning. Well, this is actually at the level of the lung epithelium, lung and the bronchial epithelium. And what we see at the level of the basement membrane is normal columnar epithelium with cilia. And the cilia are depicted down here. In this cartoon, there's a transition right at this border, and that's shown by this transition right here. Hopefully you can see how these cells look like they're organized in a column. And then over here, these cells are stratified, and they're squamous. Squamous is like a flattening of the cell. So down here at the bottom, they're a little bit rounder and fatter, and as you get to the top, they're actually squished down. You can see it as it's depicted in the cartoon. Fatter at the bottom, and then squamous orientation at the top. So where do you think this is happening? In what type of patient? What's that? Smoker. Okay? This is a classic smoker from an emphysematous patient. And we're seeing this transition zone, another metaplasia, and we're, instead of going from a squamous to a goblet epithelium, we're going from a columnar to a squamous. Why would we be going to a squamous epithelium in a smoking patient over a chronic period of time, a long period of time? What's that? Because of the pollutants like tar, other carcinogenic agents. You're trying to provide a protective layer against that harmful irritant. And the best way to do that in the lungs that don't usually see particulates, because you're supposed to breathe in clean air, is to use a barrier tissue like squamous epithelium. That makes sense? So let's just take a peek at some of the histology that's available to us. Okay, so we've got species is human, the organ is lung, the patient diagnosis was emphysema at the level of the lung as well as the bronchus. We're going to zoom in on this structure right here. So we zoom in here, and we zoom in one more, and you can see I found a region that's transitioning between columnar, here in the green means good or go, over here to more squamous epithelium. Okay? So a textbook finds much more easy to see pictures. I wanted to show you one that was maybe a little bit less obvious, but you can still appreciate there is this change from one epithelium to another. The irritation, it isn't hydrochloric acid. That was in Barrett esophagus. The irritation is actually the pollutants found. It's tobacco smoke. Okay. Now you say, aha, well, in my vaporizer, there isn't any pollutants. Well, that's actually not true. Okay? We still have trace amounts. There's probably far less. But then if you can see it, you're actually breathing in particulates that aren't normally there. Okay? Now, a lot of the glycol-based aerosols that they put in there, so you can actually have this psychology of, oh, I just had a puff and now I'm exhaling a puff. They're a lot cleaner, no doubt. It's probably a lot better for you, but I would not trick yourself into believing that it is absolutely safe. Okay? All right. Questions so far? We've already covered a lot of material, right? So we're going to keep going here for a little bit, and then we're going to take a break maybe in about 10 minutes. So, the causes of injury that we alluded to when I first kind of started talking about the motif of how it's going to work throughout the semester. The causes of injury fall into a number of different categories. You can see at the bottom, age. Age is considered a pathological injury. Okay? So one of your colleagues and I were talking in my office last week during office hours, and I said, you know, we're all going to die of something, and the moment that you're born, you start dying. Right? And it's true. It's a little morbid, but it's the reality. And so age is on this list. So anything that's a result of the aging process, if we're looking at on the exam, an older patient, a geriatric patient, I might say, okay, or I might say something like John, who's 79 years of age, experiences, you should immediately think, okay, he gave me the age because he wanted me to know I'm thinking about a pathological condition. Does that make sense? Or I say, Mark, who's 18 years of age, experiences an injury, should immediately say, okay, he's 18 years of age, he's not experiencing anything as a result of his age. So whatever happened to Mark is all I have to consider. Okay, so those are going to be clues for you on the exam. But let's back up. We can go the reverse direction just for fun. Physical agents, like trauma, okay? Nutritional imbalances, like sodium levels are off, or potassium levels are off, or sugar levels are down, okay? We'll look at diabetes, and we'll talk about nutritional issues associated with diabetes. Genetic defects, immunological reactions. We'll spend a whole section talking about different types of hypersensitivities. Okay, there's 4 big categories: type 1, type 2, type 3, and type 4. Allergies. If you have, how many of you have a known allergy to like shellfish or penicillin? There's certain drugs you can't take. There's certain foods like eggs or milk or gluten. How many have or pollen, bees? Certain times of the year your allergies all want. That's all type 1 IgE-mediated hypersensitivity. That can cause pathologies. Okay, so we'll talk about that. Infectious agents, viruses. Okay, I didn't mention it, but the helobacteria is one of the most common bacterial infections that take place within the stomach that cause those ulcerations that take place. We'll look at tuberculosis here a little bit later this afternoon. Okay, so that's another type of infection. Chemicals. We already looked at hydrochloric acid. There can be pollutants in the air that we breathe if you live in a big city. It's one of the things about Flagstaff is, you know, you're probably saving your lungs by being here. Okay? And then reactive oxidative species. Reactive oxidative species, ROSs. That is a word I would put next to it, inflammation. That's really what we're talking about, is we're talking about inflammation when we talk about reactive oxidative species. We're talking about free radical formation, right? You're like, oh, is that what that word means? Yeah, free radicals form during an inflammatory response. And what you take in your diet to kind of quench that inflammation with those free radicals are what we call antioxidants, right? Blueberries are rich in antioxidants, and that's why people really like blueberries, okay, in their diet. There's a lot of foods that are high in antioxidants that actually gobble up and neutralize a lot of these free radicals. And then hypoxia. Hypoxia was the example we used with the patient that had the heart attack, okay, or the infarct. So these are all the main categories we're going to talk about this semester. It does, I think, represent a very comprehensive list. Might there be something that I've missed? Yes, of course. Okay, but this is going to take us all semester to get through all of these different examples. So how does it actually happen? Well, back to this idea of reversible versus non-reversible. So reversible things that take place are down to this 2/3 way down the slide. So right at this transition where it goes from pink, or it goes from normal, which is like in blue, to reversible, which is in green, to pink, which is irreversible. So the normal things that take place, this is a normal cell up top, and then in the reversible injury, you can see there's some sort of injury that takes place, and you get some changes. You get clumping of the chromatin. The DNA already starts to rearrange. You get swelling of the ER and mitochondria. And you start getting alterations that take place at the level of the membrane. And if it is able to be recovered, you go back to normal. If it's not able to be recovered, and then it leads to cell death. And it can be cell death in one of two ways. It's either cellular suicide, apoptosis, programmed cell death, or it's what we call necrosis. And we're going to look at both pathways. Okay, so cellular swelling. One of the first things that we observed in these cells, if we back up to this picture, is we see that the cell has actually gotten larger. We get this swelling that takes place. We're going to talk about fatty change here in a minute. But the first one that we're going to talk about is cellular swelling. So this is referred to as hydropic change. Hydropic change is a word that means taking up fluid. Hydro for water. And you get a vacuolar alteration or a rearrangement of these storage houses or these empty void spaces within the cell. It is reversible to an extent. So these are kidney tubules. On the lower left are normal kidney tubules that you would see. Back to 202, the kidney tubule, where we're going to actually do a lot of filtration. So these are cuboidal epithelium. And you can kind of appreciate the fact that these, you can't see the boundaries between the cells. You see, here's a nucleus, 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 all the way around. Well, this is normal. This is exactly what you would expect. But in this kidney, if the kidney is actually starved of oxygen, meaning that there's a reduction of blood supply to the kidney, then you're going to start making some changes. The first thing that you're going to see is you're going to see ischemic injury in the early phase that shows surface blooding or those alterations of the membrane. You get a swelling of the cell itself. You can see a loss of organization of the nice clear tubule, but you can still appreciate the nuclei. Now, the nuclei in this one is still here. It's just really, really small, right? This nuclei is really small. This one's really small. This one looks about normal size, normal size, normal size. But if you continue to progress over to C, panel C, you lose, there's no nuclei in this tubule. This one's completely anuclear. And the swelling that has taken place is ruptured these cells to the point where you're actually losing the integrity of the membrane. That's why it's not organized anymore. You get an increase in this Turner pressure, right? So that's fluid coming in, and the pressure pushes the organelles up against the wall, causing damage. You get more of a paler color in the cell because you're flooding it full of fluid, and eventually it actually ruptures. And if you get to this stage, this is non-reversible. I would say that there's elements in this panel that are reversible, but there's also elements that are non-reversible. If you've lost the membrane, it's not reversible anymore. Now, if we look at fatty change, kind of our second feature of when things start going bad, this is an example not of the kidneys, but of the liver. So in the liver, and we'll talk about this later in the semester again, but I'll just set the stage with it today. In the liver, we can see normal liver lobule up top. You can see the three different distinct zones of the architecture of the liver. And then you can actually appreciate down here that this has been completely rearranged. You've got lipid-filled vacuoles that show up in this liver. And that's all of these open white circles are all void spaces of fat that's being stored within the liver. This is most often found in chronic alcoholism in patients. And we'll talk more about it later in the semester, and I'll point you back to this. But you won't see this in necrosis, not just in the liver. Not to the same extent. You won't see that much fatty change, but you'll start seeing elements of fatty change in all cells that start going through a necrotic response. Okay? If you look back carefully at that cardiac slide, there were lipid-filled globules that were found within the heart as it was progressing along that right side of the slide. Okay? And so this is one of the stages. You get cellular swelling and you get lipid formation or fatty change. Now, apoptosis, programmed cell death. So here's a nice little delineation between necrosis on this side and then apoptosis on this side. With necrosis, you get swelling of the cell before you actually get shrinkage. Right? It swells and then it bursts or it lyses. It's very unorganized. You ultimately get digestion that takes place. But with necrosis, you get the membrane fracturing, and that's what actually pops the necrotic cell. Over on apoptosis, you never really have swelling. You have slowly shrinkage that takes place in the cell. And what happens is you get these bloods that take place, and then eventually the bloods break off into these apoptotic bodies, compartmentalizing organelles that can be recycled. And so slowly over time, you're actually making the cell smaller, but you're compartmentalizing it off so a neighboring cell could actually phagocytose it and use some of those parts. So you never really have loss or degeneration of the membrane with apoptosis. So here's a comparison table that I think you're going to find helpful as you study. I think it'll also be helpful possibly for the post-quiz. So you might want to have it up. Okay? You won't be able to use notes and things for the exam, but for the quizzes, again, they're open book, open notes. And so this one actually compares and contrasts apoptosis versus necrosis. So let's just walk through it really quickly, and then I'm going to sort of give you a practice test question just to see how you do. So we've got apoptosis. Let's go with necrosis first. We talked about it first. Necrosis on the left, or on the right, excuse me. It affects a group of cells. A lot of times tissue becomes necrotic, like that myocardial infarct example that I gave you. You get a whole region of necrosis. It's called coagulative necrosis, and we'll talk about that after the break. But necrosis affects a group of cells. There's a significant inflammatory response. It's actually observable. You can see it under histology. You get swelling of the cell. You lose the membrane integrity. You get swelling of the inside organelles. You get random breakdown of the DNA. And then it's ultimately lysed and digested by macrophages. Macrophages come in and clean up the debris. In contrast, on the left, we've got single cells being affected at any one given time. It could be a group of cells that are signaled for apoptosis, but it's the single cell that gets the signal. Okay? Membrane blooding, but the integrity is maintained. You don't lose the membrane. You get permeability of the mitochondrial membrane. You get condensation of the chromatin. And you get organized DNA fragmentation. It's not random, it's organized. And then ultimately, the apoptotic bodies break off and they get reused. Okay? So, I want you can talk amongst yourselves, but I want you to, these were taken at the same magnification. This is using a scanning electron microscope. And I want you to tell me which one is a picture of necrosis, and which one is a picture of apoptosis. And then I want you to tell me why. Okay, so talk amongst yourselves to see if you can figure this out. And then we'll get to your question here in a second. Got it figured out? Okay. There was a question here though first. Yes. The blending is where it kind of, it's almost like you grab your skin and you pull, right? It kind of comes out, so that's the blending. And then apoptotic body, it pinches off and then it goes out. Okay. All right. Who thinks they got this down pretty well? Okay, let's see here. Try to find someone that hasn't participated yet. I haven't seen you participate yet. Let's give it a shot. What's your name?
I'm Hannah.
Hannah. Okay, Hannah's going to tell us which one is necrosis. And
So,
B
B is necrosis.
is necrosis. How many of you agree? Let's see a show of hands. Okay. How many of you disagree? Okay, so the agrees have it in vote, and I would agree with the agrees. So B is definitely necrosis. Now why? Let's have someone else share our why. Hannah did a great job with that. Over here.
Is it the loss of the membrane integrity?
You have loss of membrane integrity. It really looks almost moth-eaten, right? You see those holes in it? Okay, did you have another one over here? That's what you took yours? Shame on you. That's okay. All right, in the back. A looks like it's blooding. Okay, I would agree. That's kind of giant blood coming right out at you. Okay, did you have something else? Yeah. You can't really appreciate the nucleus in the necrotic picture. Okay, it might be hard to tell completely because you're looking through like a bunch of holes, but it does look like there's not much going on inside that cell. Okay, so that's exactly right. So this would be a classic example of how you'd be able to discriminate the differences between apoptosis and necrosis. Make sense? So before we break, I wanted to tell you some examples of when would you use apoptosis? Anybody have any ideas of when apoptosis is used? Like, I get necrosis, like a patient has a heart attack, something bad happens. Well, what the heck? Why would you have an apoptotic signal to tell a cell to die?
Well, if you look at when you have a baby teeth and they're still attached to your gum lining, at some point those have to make room for your adult teeth to come in, so that attachment has to, over time, degrade and completely disappear to make room for that next.
That's a great example. There's a lot of them, but that's a great one. That wasn't one I was going to say. Did you guys hear that? So baby teeth. When baby teeth are going to fall out and that gum gets disconnected from the tooth and allows the periodontal ligament to resorb away so the tooth becomes loose, right? And then it'll eventually fall out. You got to make room for your permanent teeth. That's a great example. Somebody else have another one?
When a virus is replicating in the cell.
When a virus is replicating as a defense mechanism. Okay, perfect. Everybody raise your hand. How many distinct digits do you have? More than one, right? Right? At some point in development, there's material, there's tissue between. All of our hands and feet are webbed early in development. And apoptosis tells those cells to actually die off to interdigitate. Okay? And you know, in some cases, you all have friends, you got kind of, they wear flippies, and you're like, oh, wow, look at the webbed foot. So everybody knows someone that's got like maybe 1 or 2 toes that are still webbed. It's a minor birth defect, it's no big deal. Can you have it snipped? Yeah. But it's just that apoptotic signal didn't go all the way down and interdigitate. Here's another one, and then I've got one slide and we'll talk, and then we'll go for a break. The thymus. Okay? The thymus is located just above the heart. And at the age of early, like preteens into your early teenage years, it's the largest it's going to be, the most pronounced. And then slowly over time, like right now, it's starting to slowly die down. And in me, in my 40s, it's probably half the size of your thymus. Because the thymus is responsible for manufacturing your learned immunity. And as you get older, into your middle-aged years, your immune system learns more than it did when it was an infant. And as you get into your 50s, you don't need that much thymus in order to manufacture all those variations of T lymphocytes. So the thymus goes through apoptosis over time. In an 80-year-old, it's almost indistinguishable upon dissection. You can barely find it. Okay, so most of you that go to med school, in most of your donors, they're going to be older patients. You'll have a tough time finding the thymus. It'll look like a gray little shriveled piece of tissue right above the heart. Okay? So apoptosis is very important for a lot of different processes, and I wanted to give you some concrete examples so you could understand why we talk about it. Okay, we're going to take a break after this slide. Necrosis. Necrosis is irreversible. You get nuclear degeneration, and you lose the nucleus and you lose the membrane. This is back to the kidney. Those are kidney tubules, kind of from a faraway map, where hopefully you can appreciate it's all pale pink. There's no purple dots that would be indicative of cellular nuclei. So here is a really nice, clear, round kidney tubule that really should look like this. But from a faraway zoom in, a zoomed out view, and you can see there's no purple nuclei present. Just completely gone. Okay? So in this section we compared and contrast necrosis versus apoptosis. And we're going to take a break. If you have a question, come on.
No. You told Dr. D.
No.
I've talked to Ray